Hey guys, today we're going to be discussing the enigma that is HemoControl. I have found that it can have a steep learning curve, so I'm hoping to support you guys in learning more about HemoControl, whether you're a newbie to it or a veteran. So without further ado, let's jump right in. When it comes to choosing whether or not to utilize HemoControl, you may find yourself asking, what is the potential benefit? As you may know, fluid overload and intradialytic hypotension are associated with increased mortality and morbidity among HD patients, so any efforts we can potentially make to reduce these instances would be to our patients' benefit. This form of biofeedback dialysis allows for a potential reduction in these hypotensive events while still allowing us to attain large UF targets. Baxter has also suggested that post-HD fatigue duration may be significantly reduced with HemoControl use. So when people are first exposed to HemoControl, it can be very overwhelming. There's a lot of different graphs and charts, there's tons of numbers, and it's just a jumble of information that's all thrown at you. So my hope is that I can break it down into individual components so that by the end you'll have a better understanding as to what all of them mean and how to utilize them effectively. So to do that, I think it's important to first outline the two main types of UF. So we have on the left a linear UF and on the right HemoControl. So I'm going to get into exactly what the difference between those two items is. So we're going to start with a linear UF, and for both scenarios we're actually going to utilize the same scenario, so 4 liters in 4 hours. So when utilizing a linear UF, it's going to pull at a linear rate. So it's going to pull in this scenario 1 liter per hour throughout the entirety of the run. So 1 liter per hour over the 4-hour run is going to give us the 4 liter target that we're after. But this means the machine is never going to stop pulling fluid unless the nurse manually takes it out of UF. And if the nurse does take the machine out of UF, it will then have to pull at a higher rate upon reinitiation of UF to make up for that lost time. The sodium will also stay at the prescribed level throughout the run, so whatever the nephrologist has decided that the sodium prescription should be for this individual patient is where the machine will keep it no matter what. And this means of pulling fluid relies solely on the nurse to make adjustments. So in our example here, you can see, so our UF rate is in green and on the right hand side here. So you can see that over the full 4 hours, it's pulling at 1 liter and it's not stopping. And then our prescribed sodium of, I'd say about 144 here is staying at 144 for the full 4 hours. So no adjustments. So that's the basics of a linear UF. It just doesn't stop pulling. It keeps the sodium at the prescribed rate. It's that simple. So conversely, we have HemoControl. So again, we're using 4 liters over 4 hours. And I do want to say up front that this image here, unfortunately, does not actually show the 4 liters in 4 hours scenario. It's just kind of an example slide here that I'll reference. So if we're utilizing HemoControl, it's actually going to pull at a higher UF rate at the start of dialysis and taper that rate over the duration of the run. So when our patients first arrive, they have the most fluid on board that they're going to, the highest accumulation of waste products, electrolytes may be out of whack. So HemoControl is actually going to pull at a higher rate at the start of dialysis when they have the most fluid available that we can take from them. But also, fluid is potentially going to shift from their tissues into their vascular space at a greater rate due to the higher accumulation of waste products and potentially their electrolytes being out of whack. So it pulls higher up front, and then as we pull more fluid, their electrolytes go back into balance, we pull off those waste products, it tapers it off until the end of the run. So at the default values, meaning that we haven't adjusted any of the HemoControl prescription, HemoControl will pull up to 1.5 times harder than a linear UF rate. So what does that mean in this scenario? So in our linear UF, it was pulling at 1 liter per hour for the full 4 hours. If we use those same values in HemoControl, what it's going to do is it's actually going to pull at 1.5 liters per hour as a maximum at the beginning of dialysis, and then throughout the run, it's gradually going to taper that value off until the maximum UF at the very end is 1 liter per hour. Now, just because that's the maximum does not mean that is what HemoControl will utilize. That's just the highest that it will potentially go, which brings me to my next point. So HemoControl will increase up to the maximum or decrease the UF rate based on fluctuations in the patient's blood volume. So in response to a dropping blood volume, based on the parameters that we set, which we'll get into in a minute, but based on that drop in blood volume, HemoControl will recognize that, and it will actually lower the UF rate to allow the patient to recover. So I'll just show you a quick example of that over on this side here. So it's hard to say without seeing the full machine setup, but I would suspect that this moment was met with a drop in blood volume on the patient's side. So HemoControl recognized it, and it backed off and gave them a bit of a break until it started to see their blood volume recover. So they were refilling, and then it reinitiated UF. The other thing that HemoControl does is it will actually increase or decrease dialysate sodium to assist in fluid removal and support blood pressure. So you can see, again, similar to our linear UF rate, or our linear UF diagram, our UF rate is shown in blue. So in this scenario, again, it does not represent the 4 liters in 4 hours, but we're starting at a max UF of about, what is that, it's hard to say, it's not perfect, but I'd say 1.4, somewhere in there. And then as the run progresses, it tapers that maximum off as we pull fluid. Similarly, as I said here, so it increases or decreases dialysate sodium to assist in fluid removal. So at the initiation of dialysis, the prescribed rate appears to be about 140. HemoControl boluses sodium, so it increases the sodium level, which allows us to pull fluid while also promoting fluid shifting from the tissues into the vascular space and promoting blood pressure support. So we're pulling at a higher rate, but we're also giving them sodium to support their blood pressure to allow us to do that. So minimizing those hypotensive episodes. So in the same way that HemoControl will gradually taper the UF volume as the run progresses, HemoControl will bolus sodium as needed potentially during dialysis, but as the run progresses, it will lower the sodium to allow the end sodium to come out at the prescribed rate. So we don't want to send a patient home with a high sodium value, because then they're potentially going to be thirsty, they're going to drink more fluid, and then we're right back where we started. So HemoControl will bolus up front and potentially a little more throughout the run, but then ultimately it does its best to lower the sodium back to the prescribed level. It is up to nursing discretion to adjust HemoControl to allow it to get back there, and we will talk about that a bit more in the future. So, easy, right? Pretty straightforward. I mean, there's not that much to HemoControl. So looking at all the different screens that accompany HemoControl, I think is another point where people get really overwhelmed. There's just, again, so many graphs, so many numbers, there's forecast values, there's input values, there's max initial UF and coefficients. It can be kind of a nightmare. So like I said, we're just going to take it one step at a time and break it down. So what we're going to do is we're actually going to start looking at HemoControl settings. So this is the screen that you would get to if you went into your prescription and looked at HemoControl to activate it. So this is basic values. We're going to talk about how to implement them and what they all mean. So we're actually going to start here in the top left and kind of work our way along step by step. So we're going to start with our HemoControl settings in the top left. So we have here our final blood volume followed by our forecast blood volume. So final blood volume is not actually something that you can modify at the start of dialysis, or rather when you're adjusting your HemoControl prescription. This is just a value that I want to explain to you, but you're not going to be adjusting it at the start of your HemoControl prescription. So final blood volume is what you've told the machine to expect your patient's blood volume to be at the end of dialysis. So in this case, the machine is thinking, okay, based on what you've told me, they should be at minus 10.2 by the end of the 4-hour treatment. So this is based upon something called the BVUF that you initially program, and we're going to get to this in the next slide. So forecast blood volume, directly beneath final blood volume, is the value the machine predicts the patient's blood volume will be at the end of dialysis. So this doesn't appear until 45 minutes into dialysis. And so for now, we're not going to focus on that. Next up, we have our UF volume. So this one's really simple. UF volume is just the total fluid removal that we have decided based on our client assessment. So this is the same if it's a linear UF or HemoControl UF. It doesn't matter. It's just how much fluid would you like to take today. So this can be changed in one of two places. So you can either change it in your regular prescription screen under UF volume or in HemoControl. The two are tied together, so if you modify one, the other will also change. And then similarly beneath it is the forecast UF volume. So again, this is just what the machine predicts they will actually get off of the patient by the end of the 4-hour hemodialysis. And again, none of these forecast values will appear until 45 minutes into your treatment. And then we have our equivalent sodium. So this value should of course reflect the sodium on the hemodialysis prescription. So you're going to put, if they have a prescribed value of 140, HemoControl should also indicate 140 because that is ultimately the value that HemoControl will try to return to by the end of dialysis. And then as previously, we have our forecast sodium, which again is the sodium value the machine has predicted by the end of dialysis. So next up, we have on the bottom left of our HemoControl prescription, our final BV-UF volume. So it sounds complicated, but it's really not. This is just the predicted reduction in blood volume per liter of fluid removed. So if you look at this one, it's basically saying that for every liter of fluid we remove from the patient, we expect a reduction in their blood volume of 3.2%. So the default value of our BV-UF, so that's if the patient has never utilized HemoControl before and we don't know exactly where to start with them, 2.5 is our default. So that's an expectation of 2.5% blood volume reduction for every liter that we take. So normally what you would do to input this value is you would use 3 or more of the patient's previous hemodialysis sessions and determine the average blood volume reduction per liter. So you'd look at their last 3 runs and figure out how much did their blood volume go down by, looking at their final blood volume, and the UF volume that you took. So you can do some simple math and determine this value. So that should be your starting point, and this will change over time. It should certainly be revisited and reviewed with every patient as they gain or lose weight or their body type changes or their diet changes. Certainly consider this value and adjust it. It's not a one-size-fits-all. It's case by case, and it needs to be reassessed. So before you actually start dialysis on your patient, you can modify this value. So you can adjust it up or down, but once you hit start treatment, this number will no longer be editable. And that's okay, because after that, we modify something different in its place. So this is only adjustable prior to hitting start treatment. So next to our BV-UF is our max initial UF and our MUF coefficient. So this one I find can trip people up a little bit. So our maximum initial UF is the highest UF value the machine will use at the start of treatment. This max UF will then decrease as the run progresses. So like we talked about earlier, so in this case, it'll start off at a 1.52 as a maximum UF. And then as the run progresses, that's going to lower itself down to the minimum UF, to the linear UF rate. Below it, we have our MUF coefficient. So this is actually how you determine what your maximum initial UF will be. So some people ask, how does the machine know what the maximum should be? Well, it's based on the coefficient that we supply the machine with. So this coefficient is quite high for me. I wouldn't actually use a 1.9 in practice, or I would very rarely use it. I would have to know the patient very well. But what this is just a multiplier. So the above image indicates that it will pull 1.9 times harder than what the linear UF rate would be. And we're going to go through this in much more detail in the next slide. So last but not least, we have our sodium limits. So this sets the amount by which the machine can increase or decrease sodium values during treatment. Generally, I find it's best to leave this on standard. I've had good results on standard, but we are going to talk about it in more detail in the coming slides. So we're going to talk about what the max initial UF calculation actually means. So in this example, I've given you, we have a treatment time of 4 hours, a UF volume of 3.2 liters, and an MUF coefficient of 1.9. Now this is just an example because for me personally, pulling 1.9 times harder than the linear UF rate is quite high, and I would have to know the patient very well to know that they could tolerate such a high pull. So the machine will determine how high the initial UF rate should be based on UF volume, treatment time, and the MUF coefficient. So I've got the formula right here. So the max initial UF is equal to the MUF coefficient, remember that's just a multiplier, which in this case is 1.9, times our UF volume over our treatment time. So UF volume over treatment time just gives you our linear UF rate. So what would the rate be if we just had to pull straight across over the full duration of treatment? So in this case, our max initial UF is going to be 1.9 times 3.2, how many liters we're taking, over the duration of our treatment, which is 4 hours. So in the next slide, I've shown that I have then determined what the linear UF rate would be. So that's 3.2 divided by 4 is 0.8 liters per hour. So 1.9 times our linear UF, 0.8 liters per hour, is equal to 1.52 liters per hour, which is what our maximum initial UF is. Feel free to backtrack and listen to this slide over again or pause the video so you can go through this in detail if you'd like. So the MUF coefficient can range from 1.2, this is more of a conservative pull, to 2.0, which in my opinion is quite aggressive. So again, that's 1.2 times the linear UF up to 2 times as hard as the linear UF. So the default value is 1.5 or 1.5 times the linear UF. So as a beginner, I would definitely recommend utilizing an MUF coefficient of 1.5 or lower. You really need to know your patients to know how they will respond to higher UF values, and I don't recommend it for beginners. So keep in mind, as we've said previously, that HemoControl will pull the hardest at the initiation of dialysis when it's easiest to do so, and gradually tapering the UF. I missed an F there. So with this slide, I'm actually going to show you a graphical representation of our maximum initial UF. So HemoControl, as I've mentioned several times, pulls hardest at the initiation of dialysis when it's typically safest and easiest to do so. And then over the duration of treatment, as more fluid and wastes are removed, HemoControl gradually tapers the maximum UF rate. So based on the parameters set by the nurse, reductions in blood volume will trigger HemoControl to reduce the current UF rate until the blood volume increases or recovers. So looking at this graph on the right, we have our UF rate on the left here on the y-axis, and then on the x-axis we have treatment time. So at the start of treatment, our maximum UF rate is high, and then over the full duration of treatment, it tapers off to what the linear UF rate would be. So that's our UF volume over treatment time. So this dotted line shows us what the linear UF rate would be, and this is the maximum. So at the very end of treatment, the maximum rate that it will pull is the same as the linear UF rate. Conversely, the minimum UF rate is our 0.1 liter per hour. So anywhere within here, HemoControl can increase or decrease their UF based on fluctuations in their blood volume, which is based upon the settings that we will input. So we'll get to that in a moment as well. So next up, I wanted to talk about sodium limits. So in our HemoControl settings, we have our equivalent sodium, which should be the prescribed sodium, whatever the nephrologist has set, followed by the sodium limits. So if you press this button, you would actually get several different options. So we have standard, narrow, and large. And what this does is it actually changes the parameters that the machine has by which it can increase or decrease the sodium value from the prescription. So in this case, with it being 140 if we left it in standard, it would be able to go as low as 135 up to 155. And that is the maximum that it would go to. If we put it in narrow, it would be able to go as low as 135 and as high as 150. Conversely, on the other end, we have large, which sets it to -7, which would be 133, up to +18. Now, this would actually take it outside of the safeguards. The maximum that the machine will allow the sodium to get to is 156. It won't actually exceed 156. So despite it giving you the large parameter, you wouldn't be able to utilize it with your equivalent sodium of 140. So typically our unit tends to utilize the standard setting for most of our UF targets, but Baxter has suggested that for larger targets above 4 liters, which again is fairly rare depending on the client, that you could utilize large sodium parameters. But typically we tend to meet our targets with the standard level with a fluctuation of -5 to +15. So as we discussed previously, the machine will endeavor to return the sodium to the prescribed value by the end of hemodialysis. However, it is up to us as nurses to monitor and adjust HemoControl as necessary to help it meet this target. HemoControl can only do so much, and it requires our interventions. So we will talk about this a bit more to come. So on the side here, you can also see a graphical representation. So our prescribed sodium being 140 using the standard limits. The maximum that it will allow at the initiation of dialysis is 155. And then as dialysis progresses, it tapers off so that the maximum it will allow is 140. And then on the other end, at the initiation of dialysis, the minimum value that it will allow is 140, and then by the end of dialysis, the lowest it could potentially go is 135. So next up, I just want to briefly talk about this little guy, the standby button. So full disclosure, I almost never use this button. I don't think it's the best design in HemoControl, which is one of the reasons that I don't typically utilize it, but I'm going to explain the intended use for it. So when you hit the standby button in HemoControl, what it's going to do is it's going to suspend your UF and sodium profiling for 5 minutes. So it's actually just going to revert those to the recommended values that are required to reach the prescribed UF volume and sodium level by the end of dialysis. And then after 5 minutes, it just jumps right back into HemoControl. So one of the reasons that I'm not the biggest fan of this button is just it offers a very short duration. It's just 5 minutes, and it gives no reminder or indication as to when standby is deactivated. So at the end of the 5 minutes, it deactivates automatically, HemoControl re-engages, and there's no on-screen reminder indicating that this has occurred. So if you needed to extend your standby, you would have to set a timer, remind yourself to go back to HemoControl, and reactivate it. Standby is potentially beneficial if you're bolusing your patient or performing another procedure which can skew their blood volume. So if you're doing something like this and you don't hit standby, it's going to skew your predictions because all of a sudden HemoControl detects, more than likely, a rapid increase in their blood volume, thinking they're refilling like crazy, and it can throw off your predictions. So hitting the standby button will pause that registration, giving you time to do your procedure, and then reinitiating it after the fact. It is worth noting that providing a blood transfusion during dialysis, of course, skews your blood volume significantly and are therefore not appropriate for using HemoControl. So you can't transfuse someone and use HemoControl at the same time. You would have to revert to a linear UF just for the safety of the patient, because HemoControl relies almost entirely on your blood volume fluctuations to make the necessary adjustments. Okay, so just my 2 cents, you can take it or leave it, but I typically find that HemoControl is easiest to utilize for pulls in excess of 2 liters over your standard 4-hour run. So oftentimes I will utilize a linear UF for pulls less than or equal to about 0.8 liters per hour. I find that 0.8 liters per hour is generally well tolerated. Of course, it's on a case-by-case basis, so consider your client's condition carefully before choosing to either utilize a linear pull or HemoControl. And if you're not sure, be sure to consult an experienced RN and get their 2 cents. That being said, HemoControl can be effectively utilized for any pull, but with lower UF volumes, I find that they typically require more modified settings or increased vigilance to ensure that your target weight loss is met. So you can utilize it for any pull, you just need to ensure that you're doing your Q30-minute checks and making adjustments as necessary. Okay, so you've decided to utilize HemoControl for your particular patient. So now we just need to initiate it within the machine. So first things first, we need to ensure that the Watson formula values for volume of distribution have been entered. So this is going to be under your prescription screen and then distribution of volume settings. So there's a variety of different calculations that can be done here, but our unit uses the Watson formula, whereby you're going to enter the patient's height, dry weight, gender, and age, and it's going to determine the distribution of volume within the patient's body. There are also adjustments that can be made if your client is an amputee, so that's something for consideration. So once those have been appropriately entered and you've entered a UF volume, you can then activate HemoControl. So you're going to do that from within the prescription menu and click on HemoControl and then activate. It is worth noting that until you have the volume of distribution and a UF volume entered, HemoControl cannot be activated. It can be activated preemptively if it's programmed into the patient's card. However, if you're not using a patient card, you need these two factors, the volume of distribution and a UF volume, before you can adjust HemoControl. So once you've activated HemoControl, you'll notice that on the main screen, the HemoControl icon actually shows up in the top right-hand corner, and then next to your UF rate and accumulated UF volume, you can see the small version of them as well. So at a glance, you can tell which machines have HemoControl on and which don't. So now that you've activated HemoControl, we need to ensure that the settings that we're using are appropriate for our individual patient. So we're going to ensure that equivalent sodium, the equivalent sodium value matches the patient's prescription. So this is what the nephrologist has set, so we're just ensuring that that's correct. Ensuring that our UF volume is entered correctly. Now, the UF volume for your patient can be modified in two different spots, so it can still be modified on the regular prescription screen under UF volume, or if you go into HemoControl, it also says UF volume. You can modify it here or in your regular prescription. The two are tied together, so modification of one will modify the other. So as we've discussed previously, once your UF volume is entered, your HemoControl settings are automatically going to populate with your maximum initial UF. And as we discussed previously, it's going to calculate this by multiplying your linear UF rate, or the volume that you're pulling over the time of dialysis, by the MUF coefficient, which is 1.5 by default. So next up, you're going to set the BVUF using the average across at least 3 runs for the patient. If your patient is new to HemoControl, you can utilize the default value of minus 2.5. Just keep in mind that you will want to do your regular Q30-minute checks and ensure you're monitoring, because they're set to the default value and this is not tailored specifically to them. You will likely have to make more adjustments until you can figure out what that average should be. Okay, so you've entered all your settings and now you're ready to initiate dialysis. So you're just going to hook your patient up as normally. It is worth noting that if you forget to activate HemoControl and you hit start treatment, you will be unable to activate HemoControl after that point. So it's really important that before that, if you think you want to utilize HemoControl, that you have it activated. You can deactivate HemoControl at any time, but you cannot activate it after start treatment. So really be careful with that. Okay, so you've initiated treatment, dialysis has commenced, and now we wait. So you're going to, of course, perform your checks as normal, your Q30-minute checks, but keep in mind that it takes 45 minutes for HemoControl forecast values to appear, so we're not going to make any HemoControl adjustments until we have those values. All right, so 45 minutes has gone by, and now you can see that we've got our forecast HemoControl values. And in a second, I am actually going to be going through the HemoControl simulator so we can go through it in real time and look at the adjustments that are recommended by Baxter. But for now, we're just going to look at kind of some examples that I put together. All right, so we're just going to take a second to kind of talk our way through what we're seeing on the screen here. So at the initiation of treatment, we've essentially told the machine to expect that by the end of the run, our patient's blood volume should be about minus 8.7. So based on what the machine has seen over the first 45 minutes, it's saying, actually, I predict that they'll end up at a minus 14. So quite a discrepancy between these two values. So we're going to use that information to potentially make an adjustment. So we've told the machine we'd like to get 3.5 liters off of the patient, but the machine is forecasting that we're actually only going to get about 3.2. So that's because there's such a large discrepancy between what we've told the machine to expect and what it's actually seeing. So the machine is giving the patient lots of breaks, which is leading to a lower accumulated UF volume because they're out of UF or at a decreased UF rate for a substantial period of time. So we're about 300 milliliters off, which isn't a huge volume. That's something that we can certainly make up with concerted adjustments. And then over here on the other side, so again, the prescribed sodium is set to 140. However, it's currently indicating that the forecast sodium, the sodium that it predicts the patient will end at currently, is 146. So again, significantly higher than what we'd like them to come out at. However, this is early in the treatment, so we can certainly work on correcting this. So the reason that our sodium is so high is we're going to flip down here to look at this blood volume screen. So you can see kind of our upper and lower blue limits for our blood volume. And then we see kind of in real time what's happening with the patient's blood volume. So because it's trending towards the bottom, what the machine is doing is it's giving the patient breaks, and it's also administering sodium to the dialysate to try and support their blood pressure and bring their blood volume back up to the area that we've kind of told it to expect. Because the machine is still trying to get them here, but it's saying, nah, they're going to end up quite a bit lower based on what I'm seeing. So it's leading to a lower accumulated UF and a higher sodium value. So it is worth noting that any discrepancy of 3 points or more between the final blood volume and the forecast blood volume will lead to a blue reminder. So on your main screen, you're going to see something that looks a lot like this. So this one's numbered 637. So HemoControl refilling rate lower than expected. So again, that's what we're seeing here. So we're telling it to expect 8.7. It's seeing minus 14. So the patient is refilling, or the fluid volume is not shifting into their vascular space as quickly as we've told it to expect. Their blood volume is dropping quicker. So that's when it gives us this blue reminder. So we're going to use all that information to potentially make adjustments to HemoControl. All right, so for this next section, what I'm actually going to do is I'm going to be utilizing the HemoControl simulator, which is available on the Kidney Campus website. If you haven't seen it before, I'd highly recommend that you check it out. And I will be providing a link to the HemoControl simulator. So there's 3 case scenarios available, and we're just going to be utilizing one of them, which I've taken some of the information for our PowerPoint. So I'm going to be doing this on the fly, so please forgive me if there's any outtakes or anything within this video, just because it will be live as we're adjusting it. So you can see that it has kind of a visual representation of the machine, and we're going to take it from the beginning as though we haven't initiated dialysis. So some of the values are already populated in here, so I'm going to go to our prescription screen here. Our treatment time is 4 hours. Our UF volume is 3.5 liters. So we have our UF volume set, so I'm going to click on volume of distribution. And then, of course, here it's saying no entry. So if we're using our patient's cards, typically this data will auto-populate. But if it's a new patient or the patient doesn't have a card, we're going to have to enter it manually. So normally we would click on here, choose Watson, and then we would hit confirm. You can see that we've got the patient's height, their dry weight, so not the patient's current weight, but their prescribed dry weight. So you shouldn't be using HemoControl on patients where we don't know their dry weight at the time. So this is for our acutes or brand new starts. We want to figure out what their dry weight is before we start using HemoControl. Their gender, and then of course the patient age, and then it gives us our distribution volume, which HemoControl utilizes to make some adjustments. Okay, so now that we've clicked on HemoControl, we can actually activate our HemoControl. However, as soon as I activate HemoControl, the simulation is going to start. So we're going to actually start seeing these values populate. So we have our UF volume set. Because it's pre-treatment, we can actually go in and normally we'd be able to modify our BVUF, but we're going to assume that either this is a patient that's new to HemoControl or that the default of minus 2.5 is actually effective for them. So that's fine. We'll leave that value as is. Our prescribed sodium is set to 140. Sodium limits are set to standard, which again, we would normally be able to adjust, but typically I recommend utilizing standard anyway. I wouldn't go narrow or large for the majority of my patients. So these are good default values. This value, in my opinion, is too high. I don't typically like exceeding MUF coefficients of about 1.5, 1.6. Again, remember, this means that this is pulling 1.8 times, almost 2 times as hard as if you were doing a linear pull, and it is a large UF volume of 3.5 liters. So our max initial is 1.57. So unless we know this patient quite well and we know that they tolerate these large maximum initial UFs, I would be quite reluctant to utilize such a high coefficient. This is just my 2 cents. But as I said, especially if you're learning HemoControl, just starting off, I would recommend starting at 1.5 or lower. So I think one analogy that I've utilized in the past that has helped people to better understand what some of these values indicate is looking at your max initial UF, like your speed limit. So this is the fastest that you could possibly go. And then looking at the final blood volume values that you input as your gas and your brake. So when you go into the machine and you actually start adjusting these values, making them more negative basically gives the machine more room to work. So making it more negative is like your gas pedal. It's saying go, go, go. Making it more positive is like your brake, saying whoa, whoa, whoa. So it will adjust these parameters. So you're going to see this a little easier when we actually look at the simulation. And I do want you guys to remember this is just a simulation. I don't think it's a perfect representation of the real world. So certainly I can take the time to sit with you looking at real patients and making real-time adjustments, and it should help to consolidate this knowledge a lot better. So we have all our values plugged in. So I'm going to activate HemoControl and it's actually going to start our treatment right away. So it goes 1 minute per second approximately. So in about 45 seconds, we'll have an adjustment to be made because we'll actually get our values populated. So it's asking us to verify HemoControl, which it will on the machine. I'm going to hit confirm, and then it'll pretend that I've actually initiated treatment on the patient. So for the first 45 minutes, we shouldn't have any forecast values here as the machine is just figuring things out. You can see their blood volume adjusting in real time. I'm going to go back to the main screen, however, just so you can see. Okay, so as you guys can see, we've got our timer ticking down here. So we're about 20 minutes into the simulation. We've got our regular blood pressure monitoring, and then of course our real-time blood volume monitoring occurring here, running at a QB of 400 milliliters per minute with our pressures being adjusted here. Some of the pressures seem like they're a little on the low side there and a little on the high side there, but maybe the patient had coughed or moved or, you know. All right, so now that we're about 45 minutes into our treatment here, we're actually seeing the blue reminder pop. So our blue reminder will pop if there is a 3-point or greater discrepancy between what we've told the machine to expect for blood volume and what it's forecasting blood volume. So you can see normally blue reminders will pop in the yellow or orange. So I think with this one, we're just on the cusp here. And normally I would go in and show you the actual HemoControl setting, the discrepancy between the two, but unfortunately with the simulator we can't. So we're seeing the blue reminder pop, and I would certainly encourage you to do this as you're learning HemoControl. There's a help option at the bottom. So if you hit help, it's actually going to walk you through what the machine suggests you should do to rectify this issue. So we're going to hit help, and then it's going to explain. So it's saying SmartScan has detected a blood volume reduction higher than expected, leading to a lower accumulated UF. So basically the blood volume is dropping quicker than what we've told it to expect. So it's giving the patient breaks, or basically slowing down the UF rate, which means we're getting less fluid off than what we would like. So of course, it's always going to tell us carefully evaluate our patient's clinical condition before adjusting any parameters. So we're going to check in with our patient. We're going to make sure they're not cramping, they're not dizzy, feeling unwell, making sure we have a recent blood pressure on them that is looking good, that it hasn't deviated significantly in the last 30 minutes. So if they've dropped 20, 30, 40 points, that's something of note, which we're going to obviously pay close attention to. So in the first scenario, it's saying, if you have a stable blood pressure with no hypotension and dry weight is to be maintained, indicating that we want to meet the UF target that we've set for the patient, it's suggesting that we decrease the final blood volume for the patient. So we'll look at that in just a moment in HemoControl as to what we would adjust. So we're going to lower potentially the parameters, which basically reassures HemoControl and says it's all good, keep going, they don't need this many breaks. Option 2 is if they have an affected blood pressure or hypotension, we could consider decreasing the UF volume, so decreasing the amount of fluid we're actually trying to take, or putting them in standby if an infusion is required, or deactivating HemoControl. I don't typically like deactivating HemoControl unless it's early on in the run. I think you can usually make adjustments to either meet your target or meet the patient's needs. Keep in mind that it takes up to 30 minutes to see the full effect of HemoControl adjustments, so you don't want to make any more adjustments more frequently than 30 minutes apart. So we're just going to go through this. So in order to clear this reminder, we would just hit the confirm button, indicating that we understand what it's saying. And now we're going to look at potentially making our adjustments. So if we go into HemoControl here, first off on this blood volume screen, we can see that the blood volume has dropped down to the bottom of the limits that we've set, and it's going to want us to make an adjustment. So for a quick second here, before we go through this, I just want to look at another screen so you can see what HemoControl has done in response to this drop in blood volume. So we're going to exit HemoControl and just look at our dialysate screen here. So you can see that we have our dialysis time in the bottom here, our UF rate shown in green, and our sodium shown in black. So initially, when we're utilizing HemoControl, based on the sodium parameters that we've set, which are set to standard, it will start by increasing the sodium in the dialysate. So it's working to support blood pressure while also facilitating fluid shifting from the tissues back into the vascular space. So it allows us to pull more fluid early on while supporting blood pressure and fluid shifting. So you can see that in response to, and again, I don't know, this may not be a picture perfect representation as to what's happening with the patient. It's a lot easier to see it when you look at a real live patient and you can correspond what's happening. But HemoControl in response to drops in blood volume typically provides the patient with a break. So they will lower the UF volume potentially to minimum for a period of time until it sees the blood volume start to recover, at which point it will reinitiate UF. The other thing that we will potentially see later on is that it will also provide sodium boluses. So initially it boluses sodium, and then throughout the run later on, we may see it bolus a little bit more as the run progresses. So we've had a drop in blood volume, so HemoControl has provided the patient with a break, which again has led to a lower accumulated UF volume. We're trying to get 3.5, but so far we're only getting 3.2. So that's why it's given us kind of a warning here. Okay, so we're going to carefully consider our patient's condition. So we've checked in with the patient. We're not seeing any hypotension. This is a recent blood pressure and we're still looking good. Not a significant discrepancy from their previous reading. They're not having any cramping, no dizziness, no complaints. Their blood volume has dropped significantly, but I would check to see if this was unusual for the patient. If we're seeing this combined with an elevated pulse, that would be concerning. So that would be something that we would note. But presently, we're not seeing anything of concern. So in essence, because we're not seeing anything concerning, we don't think that HemoControl needs to provide these breaks, which is keeping us from getting to our target. So what we're going to do is we're going to lower our final blood volume. And typically I wouldn't lower it in excess of 3 points. That's my general rule of thumb. So unfortunately, the simulator will populate the values for us. It doesn't give us a lot of free will here, but I'm going to click on final blood volume, and it's going to automatically lower it from 8.7 down to 12. So it is lowering it by just 3.3 points, so a little bit outside of the bounds of our normal 3-point limit, but pretty darn close. So we're going to hit confirm, and the machine is then going to carry on. So in essence, what we're doing is lowering the predicted final blood volume closer to this, and what you're going to see is the blue parameters are going to drop down, which gives us a lower bottom, which means the machine will not give as many breaks, which given the patient's condition is appropriate. So we're going to hit confirm. You can see that now our parameters have lowered. So the blood volume was more in the center rather than right at the bottom. So it gives the machine a little bit more room to go. So our hope is that we see this forecast UF volume improve. So we want to see the 3.2 get closer to our 3.5. And we're going to check it again. Normally we would check it in 30 minutes, but because this is just a simulation, the machine is essentially going to carry on until we get a blue reminder, at which point we will make our adjustment. So again, we're watching their blood pressure has started to decline a bit, but not significantly. We would be checking it with the patient, doing our Q 30-minute checks, watching their blood volume. We can look at HemoControl here. So we see that, at our dialysate. So we see, of course, the initial sodium bolus. It hasn't had the need to bolus more aggressively, and it hasn't been giving a ton of breaks. At this point, it's actually been trucking along quite well. So, of course, we expect to see that gradual decrease in UF volume as our treatment time progresses. Okay, so we've got another blue reminder, same as last, so refilling rate is lower than expected. And it won't actually let me go back to the main screen right now until we address this. On the machine, of course, you could, but just not in the simulator. So HemoControl refilling rate is lower than expected, so same as before, we can hit help and go through. So we're seeing a blood volume reduction higher than expected, leading to a lower accumulated UF volume. So hopefully we've actually seen an improvement. Again, evaluate your patient's condition. If they have a stable blood pressure with no hypotension, we would consider decreasing the final blood volume. So this is actually a really good visual representation of what we would do. So it's basically showing your blood volume has hit the bottom of the parameter here, or potentially in this case below, which means it's probably giving lots of breaks, lower accumulated UF. So what we're going to do is lower our parameters. So we're not doing anything, obviously the blood volume doesn't change, we just lower what the machine is expecting. So then their blood volume, rather than being below, is more in the middle, and the machine carries on happily. If they did have an affected blood pressure or hypotension, of course we would then potentially decrease the amount of fluid we were going for, or put them in standby. I wouldn't deactivate HemoControl more than likely. That's just my 2 cents. Ensure that you're not making adjustments, of course, more frequently than the Q 30 minutes. Okay, so we're back at the main screen. So we're 2 hours into treatment. Their blood pressure has dropped. So we're at 127 on 75. Still a good blood pressure, but it has dropped significantly since we started. So let's just check in with the patient. Patient says they're feeling good. No evidence of cramping, no dizziness. This is not unusual for them. Blood volume's seen a modest reduction as well, from about -10 to -14. So we're doing okay there. And then again, it's a simulation, so it's not perfect, but realistically, if we're getting the blue reminder, this should be, distinctly in the yellow or orange section. So we're going to go into our HemoControl and take a look. So we can see, obviously, her blood volume continued to decline. to the point that it's now at the bottom of the limit. So she's been getting more breaks than she was previously, which has led to, again, the machine predicting that we're not going to make our target. I don't love this simulation in that it only wants you to make adjustments when the blue reminders come up. I think small, consistent adjustments lead to a better outcome. So I think we're playing a little bit of catch up here personally. So our forecast UF volume is 3.1. We've told the machine to expect her to wind up at a minus 12. It's saying actually she's going to wind up at a minus 17. So again, significantly below where we've set it. So as long as she's feeling good, her blood pressure is maintained, what we're going to do is, again, lower the final blood volume. So lowering the final blood volume essentially reassures the machine and says, you're good, keep going. Increasing the final blood volume, conversely, tells the machine, hey, back off, they need more breaks. So we're going to hit confirm, and the machine is going to carry on. So our hope here is that we should begin to see this forecast UF get closer to our outcome here. And this is all just a scripted sequence, so I can't actually make adjustments that will deviate from the script here. What we get is what we get based on what they've programmed. Okay, so we're getting towards the end of our treatment. We've seen our blue reminder pop again here. It's saying refilling rate lower than expected, so the same that we've seen previously. Again, the blood volume is decreasing, leading to a lower accumulated UF volume. So we have the same options as we did previously. I won't go through them again. So I'm just going to confirm to clear that. One thing that I would like to note, of course, is that this is just a simulation, and I don't feel it's an excellent representation of a real-world scenario for a number of reasons. So normally, and again, this is just my 2 cents, rather than only making adjustments when the blue reminders pop, which is what this simulator allows you to do, there's no room for making adjustments in between that time frame. I suggest doing your Q30-minute checks and critically evaluating your patient's condition and the HemoControl forecast values and making minor adjustments as the run proceeds. That way you're not playing catch-up. So I think this is kind of a good example of playing catch-up. In this scenario, we only have 32 minutes left in the run, so we're right at the very end of the run. We haven't made very many adjustments. Their blood pressure is looking stable, and their blood volume has decreased by a decent margin, but again, they're stable, no concerns. But if we look at our HemoControl values, we're trying to get 3.5. It's currently forecasting that we're only going to get 3. We're not going to make up that 500 milliliters typically in the last 30 minutes of treatment because actually we only have 2.8 liters accumulated. So that's a 0.7 that we need to make up in the last 30 minutes of treatment, which is a fairly large volume, especially considering we've already removed a large portion of the fluid and we've cleared their blood for 3.5 hours, leading to likely a lower rate of fluid shifting off of the tissues into the vascular space. So I don't think this is a great representation. I would prefer that closer to the end of treatment that our forecast value is much more reflective of this, or if it's not, because the patient's condition has declined, that we would adjust the UF volume to be more realistic. So again, it's asking us to adjust the final blood volume because you can see that we've hit the bottom of our parameters. So again, I would suggest lowering this by typically around 3 points. So in this case, that's what they're doing, going from minus 15 down to a minus 18. Now I'm not going to confirm that just yet because as I do, it's going to reactivate our timer and then the scenario is going to complete. So here you can see that our forecast sodium is 138, so just a bit under the prescribed sodium of 140. And the sodium, this one I also don't know if it's a great representation of a real world scenario because the forecast blood volume has been running significantly more negative than what we've told the machine to expect. Typically what you would see would be actually more bolusing of sodium. So I would generally expect that the forecast sodium would actually be a bit higher than this, maybe like a 142, because it would likely be providing extra sodium in an effort to increase the blood volume to try and get it to minus 15. So keep in mind that whatever value we've put into HemoControl here, that's what HemoControl is endeavoring to try and get them to, So because we want them at 15, but it's saying they're going to hit minus 20, the machine is giving them breaks, so lowering the UF volume to try and allow them time to recover closer to minus 15. And typically it's also bolusing with sodium to facilitate that increase in blood volume and support their blood pressure. So I'm not totally confident that this is wholly accurate, but again, it's just a simulation. I would certainly encourage you to look at real life scenarios. This is really just to dip your toes and get a general idea as to what HemoControl actually does. So that being said, I'm going to click on final blood volume, and again, it's going to suggest a lowering of 3 points to minus 18. So we're going to do that. Again, it lowers our parameters so that our blood volume is more like smack dab in the middle of our parameters, giving the machine a little bit more room to move. So it's not giving a ton of breaks right now. It's not bolusing sodium because it's in the middle. So you can watch the blood volume fluctuate, and we're in our last 15 minutes. I would say it's surprising to me. It's somewhat impressive. In the last 30 minutes, we are going to miraculously make that jump to 3.5 from our original forecast of 3. So again, I don't think this is wholly accurate, but it's going to tell us that we made our jump. So congratulations, we've done it successfully. So our target UF volume was 3.5. We've come up with a blood volume of minus 19. And achieved our UF volume of 3.5 liters. And then it's going to kind of go through the adjustments, the 3 different adjustments that we made. So again, my 2 cents is that rather than only making adjustments when the blue reminders pop, I think it's more effective to be proactive. Consider your patient's condition, look at the forecast values, and cater your treatment to them rather than only when the machine tells you to do so. But you can take that with a grain of salt. So there are other patients. You can certainly go through and look at the different scenarios. I would encourage you to do so just to get kind of a preliminary view. But really, the best HemoControl learning that you're going to do is going to be in the field when you're actually dealing with real patients, real scenarios, and getting to know your individual clients. So to close things out, I'd just like to review some general rules for operating HemoControl. So when you're making your Q30-minute adjustments, you want to avoid adjusting more than one parameter at a time. I say avoid because there are circumstances where you may adjust more than one, but typically, especially while you're learning, you don't want to adjust more than one value. Keep in mind that it takes 30 minutes for any of your changes to be apparent, so don't change settings any more frequently than this. Especially while you're learning, I would encourage you to not make adjustments to the final blood volume, this is during treatment, of greater than around 3 points. Anything larger than that makes for more aggressive changes, so I strongly encourage small, sustained changes rather than making individual large changes. So do your Q30-minute checks and make adjustments as necessary. Make sure you start early. So as we reviewed, after 45 minutes, you're going to start having those populated values, those forecast values, and that's when you can start making adjustments to HemoControl. If you don't catch these issues until 2 hours into the run, you're going to be playing a lot of catch up, which is bad for the patient and bad for your end outcomes. You don't want to be making aggressive changes to try and make up for lost time. Make sure you monitor your patients for a rise in heart rate accompanied by low blood volumes, as this can be indicative of an impending hypotensive episode. Always prioritize the well-being of your patient over hitting your targets. Critically think and evaluate your patient condition before any adjustment. It's not all about hitting the patient's goal weight. Per Baxter's instructions, they have suggested that no more than one adjustment should be necessary during treatment. I note this simply because it comes from the manufacturer. However, in my experience, this is not the case. Multiple adjustments are typically required. However, if you're frequently updating the BVUF of your patients, you will be catering their HemoControl values specifically to them, and you should require fewer adjustments to reach your target goals. Alright guys, that's it for me. This is my first attempt at doing kind of a HemoControl crash course, so I'm certainly open to feedback. I'd love to make adjustments in the future and provide more insights into any areas that you'd like more information on. Thank you so much for watching the video, and please let me know what you think.